Good afternoon. Welcome to Regional Distance Learning Clinical Seminar Series. Today's topic is Aging with HIV and speaker Dr. Ravinder Kaur Sachdeva. Dr. Ravinder is currently working as a senior medical officer at ART COE PGIMER Chandigarh. She was associated with WHO for strengthening routine immunization and surveillance for vaccine preventable diseases. She has published more than 26 papers in international and nationally indexed scientific journals of high impact and has more than 705 citation. Now I request Dr. Ravinder to start the session. Thank you.
Good afternoon. So today I'll be discussing about aging with HIV. So we all know that with successful administration of an antiretroviral therapy and maintaining adherence to combination ART, we this deadly virus infection, it has been transformed into a manageable, lifelong chronic disease. And even so, successful long-term treatment of HIV is associated with increase and accentuated development of non-AIDS related pathologies. So people with HIV who are on successful treatment as compared to uninfected individuals, they are now showing greater incidence of age related disorders. And so I'll be discussing this session in detail, changing trends in age with HIV and considerations before treating HIV in aging, and management about HIV related comorbidities, which includes diabetes, cardiovascular diseases, osteoporosis, renal disorders, hypertension, non-AIDS defining malignancies, mental health, and frailty. So this diagram is showing the proportion of people who are living with HIV uh, of various age groups. So we can see that people who are above 50 years, this proportion has significantly increased over years since 2005. And these people are more likely to present now late for HIV diagnosis and care, and are more likely to have been diagnosed with HIV infection while presenting with other illnesses in the clinics. And so this diagram, pie diagram, is showing that people who are diagnosed above 50 years are amounting to 55% in one of the study, uh, and newer infections in this age group is amounting to 17%, and those people who are diagnosed late are around 28%. So, compared to the younger patients, older people, they are opting for a lower voluntarily testing, and also physicians, they suspect lesser number of times HIV infection um, in these individuals, and there is late presentation for diagnosis and care in people who are above 50 years of age. And if we see percentage of newer infection in more than 50-year-old, it is only 17%. And there's this may be these may be that there's lack of awareness of HIV risk factors in this age group. Some older people, they are now newly single, widows, divorced, or while being married, they may have ignored the HIV prevention messages. And there is very little HIV prevention education in this particular age group. And risk of HIV infection actually is not being perceived by these individuals as such. And they present, so they might this might be the kind of underlying factor for having a newer diagnosis, newer lesser number of newer diagnoses in the patients who are more than 50 years of age. Also, those people who are diagnosed late, which are 28%, this may be that they they may be finding that screening, um, uh, they may not be appreciating that risk of having high risk behavior, and they may be presenting late for diagnosis and care. So this bar diagram is showing the changing pattern of the cause of death in the aging individuals. So there are various colors you can appreciate from in this diagram. In 1984 to 1995, you will see that most of these patients, they are presenting with the AIDS related morbidity and mortality, while this percentage has significantly this proportion has significantly reduced subsequently, and now we are seeing more of the non-AIDS defining causes, non-AIDS defining infection, other comorbidities in the form of involvement of liver, cardiac involvement, CNS involvement, nephropathies, and other causes are they are they are actually coming up into a significant proportion as compared to the AIDS related morbidities and mortalities. Amongst the top 10 causes of death in the aging individuals, we can see that heart incidences, lung disorders, stroke, and brain hemorrhages find a significant proportion of the total number of death, while the other causes, respiratory illnesses, diarrheal, tuberculosis, these are in a lower percentage of the patients. And similarly, the other causes also, there can be some other causes of morbidity which are having a very low percentage in these individuals. So, for the non HIV comorbidities, if we compare HIV positive person with the HIV negative amongst different age groups from 45 to 50 to till 65 plus age group, we can see that significantly more of the other comorbidities, hypertension, angina, myocardial infarctions, peripheral vascular diseases, malignancies, they are forming a significant proportion of patients who are presenting with the comorbidities. So we can see that there are various this bar diagram is showing various colors of the presentations. Those people who have no comorbidity, these have been shown by blue color, and orange is for the patients who have one comorbidity. For patients who have two comorbidities, they are presented by the green color, and similar yellow is for the patients who are having more than three comorbidities along with the HIV infection. So we see that from in the 65 plus age group, having three plus comorbidities, it is quite a higher than the individuals who have HIV infection amongst in the 45 to 50 year of the age group. So having comorbidities also increases the risk of being on the multiple therapies at the same time of having antiretroviral therapy. So polypharmacy is another issue which is being faced by those individuals who are diagnosed late in the age with HIV infection. So there is increasing frequency of polypharmacy in patients who have HIV infection as per their advanced age. And as patient age increases, so does the proportion of patients who are taking one, two, three or more medications in addition to their antiretroviral therapy. So there also comes challenges while managing these individuals in the form of managing polypharmacy. There is increasing expenses on the patient pockets with decreasing income in the advanced age. There is high pill burden. There is also the increased visits to doctors or laboratory for testings, which restrict, and there is along with their advancing age, there is limited mobility, and there is increasing dependence on the other family members in these individuals. So, if we compare the risk of non-AIDS mortality after HIV diagnosis, so there are two colors being used in this bar diagram, a darker blue color and a lighter one. The darker is representing those individuals who are diagnosed with HIV in their first year of life, and mortalities, causes of mortalities in those, and the lighter one is after first year of the life of first year of treatment initiation. So we see that the there is decreased event risk as a patient is on the antiretroviral therapy, and there is less this risk reduces after first year of the antiretroviral treatment initiation. So all cause mortality, and having non-AIDS death, non-AIDS infections, non-AIDS malignancies, cardiovascular diseases, liver diseases, and other causes. These all reduces once the person is on antiretroviral therapy for a longer duration, and this risk has been compared in the population in the first year of life and after the first year of initiation of the antiretroviral, not the first year of life, first year of antiretroviral treatment initiation and after first year of ART initiation. HIV treatment dramatically decreases the risk for all cause mortality, non-AIDS mortality, and non-AIDS infection. And however, we also at the same time we also appreciate that the number associated with the lighter blue bars, it remain more than one, which suggests that despite the dramatic decrease in the number, the risk has not completely normalized. So now this is the triad of factors which should be taken into consideration when we appreciate cardiovascular and other metabolic complication in the context of HIV infection. The first is the inherent to patient's risk pre-HIV, and whether there are social factors or genetic factors or behavioral factors which are traditionally associated with the increased risk, such as smoking, dyslipidemia, hypertension, diabetes, obesity. The second one is the risk imparted by the infection itself, HIV itself, the inflammation induced by the virus itself, having co-infection itself, having hepatitis co-infection, having other co-infection itself, or if the person is presenting late in the course of the treatment diagnosis. The third group of the factors which is should be taken into consideration while we manage patients in the aging in the HIV in the aging group is the antiretroviral therapy itself. It is important to look for the way for in this way, because treatment decisions are to be taken depending upon cardiovascular risk and whether some other traditional risk factors is coexisting. Having a suppressed viremia is there or not, as we need to decide for the antiretroviral drugs to be given in this age group as well because of coexisting comorbidity. So, to manage for the age-related non-HIV comorbidity, first we will be discussing about diabetes. There is relative risk of diabetes in HIV-infected population, which is about 1.2 to 2, and prevalence of impaired glucose tolerance is seen as 18 to 35%, and having diabetes is 9%. So we should be doing fasting glucose monitoring, and if the levels are more than 100 to 125, we should be considering the post meal assessment in these individuals. And fasting glucose monitoring should be done every 6 to 12 months in all the patients. And considering testing 1 to 3 months after starting or modifying ART, of which we should also always keep in the mind that if person is on lopinavir or base therapy or some NRTIs which has the propensity to cause the blood sugar, so that should also be taken into the consideration. We need to manage patient as per the individual case treatment, and our goal for prevention of raised blood sugar is should be like HbA1c levels to be less than 7 to 8% in the aging population. So this table is showing the antiretroviral drug interactions with various oral hypoglycemic agents, and in from all the this groups, we should be having we should be knowing that the main class of ART that has been implicated for this adverse events are protease inhibitors. NRTIs, it has also been shown to cause insulin resistance. However, to date, no direct mechanism has been found with NRTIs. And the main we should be as far as the drug interaction is concerned, that we should remember that dolutegravir significantly increases metformin levels. So while giving metformin to the patient who are on DTG based therapy, we should be knowing that dose should not be above 1000 milligram per day. And the other class of drugs, these do not impact much the have much impact with the oral hypoglycemic agents. For the cardiovascular disease risk burden, there, as the patients are advancing with the age, there is increased prevalence of cardiovascular diseases, and there is around 1.5 to 2-fold increased risk of cardiovascular events in the patients who are aging. And this risk has is 4.5 fold increased risk of sudden cardiac death in the aging population. And if we see the relationship of cardiovascular disease in HIV and antiretroviral therapy, we should remember that it is not always linear. This is more of a U-shape relationship, which we see in this diagram. When antiretroviral therapy is initiated, there is rapid decrease in the risk of cardiovascular events, and this risk then starts to increase again slowly over time. And in this slow increase phase, main factors are traditional risk factors that the patient might have, like patient might be having underlying hypertension, he may be having substance abuse in the form of smoking, or there can be persistent inflammation from HIV, and possibly also the use of certain antiretroviral agents, particularly the older drugs that were used to treat HIV, that we were using HIV for the treatment of HIV in the past. Therefore, whenever we think about cardiovascular risk in patients with HIV, we need to remember this U-shaped curve, and this very high risk at the beginning before starting therapy, dramatic decrease after starting therapy, and then traditional risk factors starts playing a important role, and this risk increases over time. So now for metabolic syndrome in HIV, which has received much attention in the recent times due to increased awareness of association of metabolic syndrome with the diabetes, cardiovascular diseases. People with HIV, these have metabolic abnormalities which resemble metabolic syndrome. There is hypertriglyceridemia, there is low HDL cholesterol, there is insulin resistance, there is obesity, hypertension, which all are associated with the metabolic syndrome. And this demonstrates the wide reaching effects of this syndrome and the importance of its prevention and management. So, visceral obesity defined by the waist circumference of 90 centimeter in men or 80 centimeter in the women, having a low HDL cholesterol levels of less than 14 males, less than 15 females, high triglycerides more than 150, having insulin resistance in the form of fasting sugar levels of more than 100 milligram, or being treated for hyperglycemia, hypertension defined by systolic blood pressure of more than 140 and diastolic of more than 90, or being, if the patient being treated for hypertension, so presence of at least 3 will point towards the metabolic syndrome. So we need to identify the risk in the management of these events in aging population. The first important step is for the risk identification. We should take the history of we should be asking patient for having on treatment for hypertension or diabetes or for dyslipidemia, having obesity, physical inactivity, tobacco use, excess alcohol consumption, unhealthy diet and nutrition, and family history of any cardiovascular event. Risk assessment is important to do for the cardiovascular disease management. Assessment shall be done at the time of registration in HIV care for aging population or ART initiation, at 3 months and then at 6 months of ART initiation, and then it should be repeated every 6 monthly thereafter. We should be asking the patient the history of any heart disease, stroke, diabetes, or hypertension, history of any angina, breathlessness, numbness, weakness in the limbs, weight loss, increased thirst, polyuria, puffiness face, swelling feet, having hematuria, and any past or present treatment or medication for any cardiac illness or hypertension or any other comorbidity, current or past substance abuse, specifically for tobacco, alcohol, smoking, the kind of lifestyle, whether it is sedentary or active lifestyle, having premature heart disease or stroke in the first degree relatives. So this history should be taken at various time points, and we should be assessing our patients for BMI, waist circumference, blood pressure monitoring. We should be assessing for sign or symptom of diabetes. Examination should be done, and lipid profile monitoring should be done for such patients. Then we should be advising these individuals lifestyle modification, which should be advised to all the patients, and then pharmacological therapy, depending upon the various reports which are available with us. Having We should be advising for lipid safe antiretroviral therapy. We should be advising at the same time lipid lowering therapies and managing metabolic syndrome and diabetes, and advising patient to avoid alcohol, smoking, tobacco, and other substance use. So lifestyle modification is advised to all the individuals. The diabetes prevention control program provides a unique opportunity to begin to address these issues, and it involves actually large number of samples has been taken in this, and patients were advised for lifestyle modification, cessation of smoking, lipid lowering drugs were also advised, and then this has actually brought very good results. We should be advising patient to avoid tobacco, smoking, eat healthy diet, and for a regular exercise, which is actually at least 150 minutes of exercise a week to lower cholesterol and the blood pressure. So now graph is showing you the, I mean, it is we are trying to show that the risk, if we are advising lifestyle modification to all the patients and we compare this with metformin and with the placebo group, we can see that there is a significant reduction in the individuals, significant difference in the individuals who have been advised lifestyle modification as compared to the individuals who are only on metformin or on the placebo therapy. This has been, as I just mentioned, in the diabetes prevention program, which this study has been done, and then the various results have been compared. This lifestyle intervention and metformin each actually reduce the development of metabolic syndromes in the participants, and the impact of lifestyle interventions were much more marked than that of metformin or placebo group. So for this table, which is showing the management of hyperlipidemia, as we have categorized our individuals to low risk, moderate risk, high risk, or very high risk based on various lab parameters and other indicators, we should be advising our patients to have a to go for statins, those who are having the raised lipid levels, and our aim should be having a non HDL and LDL level less than 100 and less than 70. Statin therapy is actually recommended for patients with hyper cholesterolemia, but a number of statins these are actually likely to interact with protease inhibitors as well, particularly ritonavir, and care must be taken if the person is on these therapies. NRTIs and NNRTIs, these are not generally affected by co-administration of statin therapy, and this is just to I mean, an NRTIs we are not using these days, but still it is just important information to note. And with integrase inhibitors, statins, which can be safely given, atorvastatin, this can be safely given, rosuvastatin can be safely given. So this is there is not of much interaction with the therapy which we are using as first line therapy. And statins actually reduces cardiovascular risk and development of these events by 44%. Phenofibrates can be used for those individuals who have triglyceride levels above 400. And the maximum dose of statins, that orvastatin, which can be used, is 40 to 80 milligram per day, and rosuvastatin at the same time 10 to 20 milligram. But we should be avoiding simvastatin and lovastatin in our patients who are on and protease inhibitor based therapy. So there are risk assessment calculators available. This one of this atherosclerotic cardiovascular disease risk estimator calculator, which is available online, which I'll let you know the site at the end of the presentation, which helps to design the risk reduction protocol, advice for cessation of advice for lifestyle modification, cessation of smoking, statin therapies, hypertensive medications, aspirin therapy, and we assess the risk score and then advise patient accordingly whether this person is low risk or into the high risk of the having these events. So now for osteoporosis, which is seen in the aging population in a very large number of cases. um, so like other comorbidities in HIV, this osteoporosis in HIV person is actually complicated and actually dependent on so many factors, which with also some contribution from antiretroviral therapy and other co-infections and comorbidities as well. Certain times there are certain risk factors, and chronic HIV infection itself and other immune dysfunction itself has an impact on the osteoporosis. And in addition, both there is actually frailty and fall risk, which interacts, which actually brings this older age and HIV a challenge to manage people who are within the advancing age. The factors could be patient individual patient dependent itself, like individual patient dependent itself. There can be a risk factors, like in the smoking, a patient might be having chronic alcohol, vitamin D deficiency, hypothyroidism, which actually brings derangement in the bone metabolism. As I mentioned, HIV infection, inflammation, low CD4 counts, high viral loads, co-infection. This also brings down the derangement in the bone metabolism and the ARTs itself, and toxicity drugs. Toxicity could be there because of antiretroviral therapy, which can also bring a derangement in the bone metabolism, which result in the increased risk of fractures or having the avascular necrosis in the joints. Then the risk of osteoporosis in HIV in women, in those in HIV infected women and men, we see in both these diagrams this is significantly higher in HIV individuals as compared to those who are non-HIV in all age groups. And there is 6.4 fold increased risk of low BMD and 3.7 fold increased risk of osteoporosis in HIV patients. If a person is not on antiretroviral therapy, HIV infected, the prevalence seen as 67%, and with who are ART experienced, this is 80.4%. Risk of percentages of osteopenia and osteoporosis are quite high in these individuals as well, 63.4% and 36.6%. This has been seen in one of the study by Dravid et al. So assessment is being done by FRAX scoring system, which is again an online tool which helps us to assess the risk of osteoporosis. So it's if a score of more than prax is actually a tool which is developed to evaluate the fracture risk of patients, and it is actually individual patient based model which integrates the risk associated with the clinical risk factor as well as the bone mineral density at maybe at the femoral neck, or this has been actually this helps to assess the risk of the fracture in the patients. If a frac score of more than 5% at more than 5% for a hip fracture at age 70, it means that the patient needs treatment along with the lifestyle modification. Amongst the lifestyle modification, we advise if some substance abuse is there, like smoking, alcohol, this has to be stopped, and exercises are advised accordingly. For the pharmacological therapy, regular vitamin D supplements and calcium supplements are advised. And we sometimes we need to substitute antiretroviral combination from tenofovir to abacavir based therapy, or tenofovir alfenamide, or if a person is on protease inhibitor based therapy, we and is being diagnosed with osteoporosis, we advise to change it to DTG based therapy. Bisphosphonates have a role in this management also. So the studies have compared tenofovir disproxil fumarate with tenofovir alfenamide, where TAF-based regimen. These have less impact on the bone mineral density as compared to the TDF-based combinations. So there can be osteomalacia or osteoporosis, which we need to differentiate. Where in osteomalacia there is decreased bone matrix mineralization, there is bone pain, tenderness, and risk of fracture is there in both the cases. But then there is low calcium levels, low phosphate levels, increased alkaline phosphatase, and vitamin D levels are quite low, and raised PTH levels. We need to treat such patients with vitamin D supplements, and we need to treat the underlying cause. And whereas in osteoporosis, we may need to give bisphosphonates, and we mean patient can be having there is actually the loss of bone mass, and patients with in HIV, there are multi factors associated for osteoporosis. They can be clinically asymptomatic, and they can have normal biochemical parameters. So and x-rays may show osteopenia only. Then the treatment part, in the treatment part, bisphosphonates, they have a significant role. So if calcium supplements are advised to patients who are on DTG based therapy, we should be under fasting condition, we should be advising that DTG should be given 2 hours prior or 6 hours after the supplementation. For renal diseases, in the aging individuals, individual predictors of new onset kidney disease, there are individual risk factors, which is BMI, smoking, hypertension, age, or diabetes, which has a role in the development of renal new onset kidney diagnosis of onset kidney diseases in HIV. And so if we should be assessing our patients for whether it is a low risk renal disorders, or having a high risk. We estimate the creatinine levels, we estimate the protein urea if it is there or not, estimate the protein creatinine ratio, what is the age of the patient, and if GFR is more than 90 and age is less than 50 and protein creatinine ratio is less than 200, this patient is categorized as a low risk patient, and we offer this individual a standard antiretroviral therapy. While if this person comes as a high risk, having a GFR of less than 70, above 60 years of age, having infection with hepatitis C, having comorbidity in the form of diabetes, hypertension, or cardiovascular disease risk, we should be avoiding nephrotoxic antiretroviral drugs in these patients, which is we should be avoiding use of TDF, atazanavir based therapy. And we if we are giving some NRTIs which needs dose modification, that needs to be done, and um, like lamivudine, we need to modify as per the creatinine clearance. Exception to this NRTI group is the abacavir, which can be given in the full dose in the patients who are with the high risk renal disease. So now the non-AIDS defining malignancies, for which the we should be doing the regular screening. I will be covering few of these, like the cervical cancer screening, which should be done for individuals at the time of ART initiation, and repeat screening within 3 years if the initial test is negative. For women who have been treated or who are on the regular follow-up, screening at 1 year should be done. So this for this screening, visual inspection with acetic acid is done, and advised accordingly whether it is required at 3 years interval or at 1 year interval. So similarly, breast cancer screening should be done for all women who are living with HIV for more than 30 years of age, and this screening should be done at ART initiation and then at every 1 to 3 years after ART initiation. Screening for oral cancer for all the individuals who are more than 30 years of age. This should be screened using oral visual examination. At regular interval, we should be advising these individuals for to stop tobacco smoking, and we should be screening for oral cancers annually, at least annually, for such individuals. Mental health assessment is also important in the aging population. And there is actually stigma associated with the disease, rejection by the family members, there's financial insecurity, there's more of dependence of the aging population, and fear of disease and death, which actually induces mental issues in the individuals. And then over 50 to 70 5% of study group of older adults with HIV, they show depression, and this causes non can be a cause of non-adherence to all medications, which includes ARVs as well. And we to a person who we have in ART center, he's getting ART medicine, but having depression and he's not taking it. So this can be a kind of that patient. We need to address the mental health issues if it is found in any of the individual. And so screening for depression is very important before initiation of ART, and thereafter every 6 monthly. There are two simple questions which help us to assess whether our patient is having sign of depression or not, which includes that the question of having in the past 2 weeks, has a patient been bothered by feeling down, depressed, or hopeless, and during the past 2 weeks, has the patient ever been bothered by little interest or pleasure in doing daily activities? So these two importance will are very important indicator to assess if some mental issues are being going on in the patient or not. So then is the frailty. So this is actually in the patient in the advanced age, having three out of these five things, having unintentional weight loss, self reported fatigue, having low physical activity levels, having weakness, and slowly walking speed. So the slowness in the walking speed, these are the signs of the frailty. So if we compare these signs with in HIV infected with the HIV uninfected, we see that there is significant higher frequency of patients, HIV patients having these signs, like having unintentional weight loss, weakness, exhaustion, slowness, and low physical activity, as compared to those who are not infected with the HIV. So we should be advising our patient. for these things, so as to reduce this incidence, like regular exercises, physical exercise, having self-help groups, social networking, which is very important. Certain times we need to go for nutritional interventions to prevent this occurrence of reality in this population. So we have to advise as per the case based scenario. And advice is given as per the, like, what kind of lifestyle patient is having. So accordingly patient is being advised, and the diet patterns and other emotional support system. So this needs to be worked up when we need to manage the reality. So actually this has to be beyond the prescription which we give, like nutritional advice involving family support system, who is the caregiver, what kind of support patient is having at his home or at his workplace. We such questions needs, certain times we need to assess these questions by asking open ended questions to patient. It is some certain times we need to build up our rapport with the patient, so that he can come up with the issues which is being faced by the person. For these things, we should be assessing our aging population for mental illnesses, and we should be trying to avoid multiple health visits for these individuals. A comprehensive healthcare package is to be given, so that their visits to hospital or health settings should can be minimized. So we need to strengthen our screening strategies for the population who are aging. We need to advise lifestyle changes to these individuals. For to manage comorbidities, supportive therapies needs to be given. To manage osteoporosis, supportive therapy needs to be given. We need to optimize our antiretroviral combination if some kidney disorder or comorbidity is coexisting. We need to have a kind of we need to assess our aging population for mental issues. So all this actually bring a comprehensive package of treatment to the aging population, which should be done. And if some vaccination is to be advised to our aging population for some illness, that has to be assessed and advised accordingly. And having a rapport with the patient, listening to them is very important, so that they can come up with the issues if they are facing at the hindsight. So these are the tools which I mentioned in my session. Like these can be these will help us to assess various risks. Like for drug interaction, this site is there. We can have a look on this site tool. If we have to advise some drug and our patient is on antiretroviral therapy, the combination, we can look into this site to look for any drug interaction. For GFR measurement, this also site is there. For DEXA, for FRAC scoring also, which I mentioned, this tool is there, which can be seen online as well. Cardiovascular risk scoring can be assessed using this ASCVD estimator tool. And for drug resistance, also this site is there, which help us to assess whether antiretrovirals are having any resistance or not. So this was all about this session. If there is any question, please ask me.
Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Thank you, Shweta.
Thank you, ma'am. Thank you to all
Thank
the
you.
participants for patient listening. We'll conclude the session now.
Thank you.
Thank you, ma'am.
Thank you, iTech. Thank you so much.